Have you ever seen a person with tongue biting, especially the side of the tongue, with drooling of saliva, arching of the back, lip move in flaming fashion, and the eye roll upwards? So into this video we will see epilepsy and the differences between epilepsy and a seizure, because it is not every seizure that is epilepsy. So what is seizure? Seizure is abnormal electrical activity of the brain resulting in abnormal motor, sensory and psychomotor experience. Every abnormal electrical activity of the brain is not seizure. It has to be followed by abnormal motor, abnormal sensory, or psychomotor experiences, which is abnormal. Every seizure is not motor. It depends on the location of firing in central nervous system. Damage to precentral gyrus, which is the motor area in the cerebral cortex, which results to sudden movement of limb. Damage to postcentral gyrus, which is the sensory cortex, will result in tingling sensation in a patient. Damage to temporal lobe, especially the gustatory area, patient might take something which is not truly there. And damage to occipital lobe, that is the visual cortex, patient might see something which it is not there. What is epilepsy? The intermittent recurrent tendency to develop seizure. That is many seizure, that is epilepsy. What is epilepsy? Epilepsy is the abnormal spontaneous recurrent abnormal activity of central nervous system, which may clinically manifest as abnormal motor, abnormal sensory, and abnormal psychomotor experience. Epilepsy should not be over or underdiagnosed. When we overdiagnose a patient with epilepsy, we will expose the patient to many years of drug usage, which may produce a lot of toxicity and side effects, and we are stigmatizing the patient socially. What are those motor experiences? We have tonic, clonic, tonic-clonic, atonic, and myoclonic. So in a bit, we are going to talk about every bit of those. What is tonic? When agonist and antagonist group of muscles simultaneously contract or fires, it will result in sudden stiffness. Let's say flexor of the elbow and extensor of the elbow simultaneously fires. The patient will have a stiffened body. Then clonic, when agonist and antagonist alternately fires. Okay, it will result in jerky movement. The flexor will fire first, then the extensor will fire. Then tonic-clonic. The agonist and antagonist will simultaneously fire, then agonist and antagonist will alternately fire. First and foremost, tonic-clonic, there is a jerk, then there is a stiffness. First, there is a stiffened body, then a jerk, as the name suggests. Then we have atonic. Electrical activity in the motor area suddenly goes down, and the body loses tone, basically. Myoclonic. Some part of the body suddenly jerk involuntarily and continuously. So, clonic and myoclonic. In clonic, there is a single jerk, and in myoclonic, there is a recurrent jerk. What are those motor experiences? We have somatic, spatial senses, and visceral senses. Somatic, sometimes the patient might feel the hand is burning in fire. Then visual senses, the patient might see something, maybe a lion, maybe or something. Then visceral senses, there is abnormal cramps and nausea, which will involve the insula. Editor will put the picture of insula right here so that you can see it. Psychomotor experience, which is also known as temporal lobe epilepsy. Patient might have abnormal tastes, abnormal sense of fantasy, which cannot be differentiated from reality, which is déjà vu, and over familiarity. You do not know someone, then suddenly You come across that person, you say, I know this person. That is deja vu. Of epilepsy, we have partial epilepsy, partial becoming generalized, and generalized epilepsy. What is partial epilepsy? The onset of seizure is referable to one hemisphere. Maybe when the left side is affected, you might see the clinical manifestation on the right side of the body. Then it may be clinically detected by thorough clinical observation and ECG, that is electroencephalogram. It's just an electrode which are placed in the cerebral cortex, and we must see the electrical activity of the brain. Partial epilepsy might be simple or complex. If it is simple, the encephalon is not affected. The patient will be consciously. But if the encephalon is affected, the patient will be unconscious, mostly. What is generalized seizure? Those types of generalized seizure, we might see the absent seizure, tonic-clonic, myoclonic, atonic. All those five we've said. The only one we'll explain right now is absent seizure. It's mostly started in childhood. The patient will have a brief attack and it will be multiple. And when the child grows, it will go out of that absent seizure to tonic-clonic in most cases. What are the causes of partial seizure? It might be idiopathic, which is less common. Commonly, we don't know the cause of that epilepsy. Then it might be a tumor, which we would use MRI to find the small tumor in the cerebral cortex, and toxoplasmosis, which affect the retina mostly. There is a parasite known as Toxoplasma gondii, which is gotten from a cat. Then the cat will transfer the parasite to human being. Then berry aneurysm and cycle of Willis. When it is ruptured, it will cause subarachnoid haemorrhage. Then causes of generalized seizure. Cerebral birth injury, it might be hydrocephalus. The cerebrospinal fluid will be blocked, and the head of the baby will be gigantic in nature. Then some drugs like penicillin, anti-malarial drug, cardiac, antiarrhythmic, psychotropic drug will cause generalized epilepsy. Alcohol withdrawal is also something that causes this generalized epilepsy. Then electrolytes imbalance like hypocalcemia, hypomagnesemia, hyponatremia, hypoglycemia. All this might cause generalized seizure. So let's see the clinical features of seizure. The patient will have a tongue bite, especially the side of the tongue, urinary incontinences, the limb will be moving in flail fashion, the opening of the eye will be resisted. So then there is something called slow seizure. It is not true seizure, but it resembles seizure. In children, like girls especially, when they are exposed to sexual abuse nature, they might manifest something like seizure in their life. That is false seizure. It is not true seizure. Investigation. The first thing we are going to do in investigation, we go for electroencephalogram. This abnormal electrical activity of the brain might be detected using some electrode which are placed in the cerebral cortex. And then we go for CT scan or MRI to visualize the tumor which causes those abnormal electrical activity in the brain. Then check the underlying cause. We go for urine analysis, blood tests, glucose level, electrolyte imbalances might be checked. Then what are the drugs used in this epileptic patient? In partial seizure, the first line drug we go for is carbamazepine. And in generalized seizure, the first line drug is valproate acid. And then the second line drug in partial seizure is valproate acid. And the second line drug in generalized seizure is lamotrigine. The broad spectrum of anti-epileptic drug is valproate acid because it can control partial seizure, general tonic-clonic, general abscess seizure, myoclonic seizure. Then absent seizure, the first line drug is etosuxamide. The second line drug is valproate acid. Myoclonic epilepsy, the first line drug is valproate acid, second line is clonazepam. Then partial seizure becoming generalized. The first line drug is valproate acid, the second line is lamotrigine. It is same as general seizure. Then status epilepticus. What is status epilepticus? It is a condition where there is continuous seizure and seizure attack in which in between the attack the patient do not regain his consciousness. It is a serious condition because the prolongation might cause severe brain damage and even death. What are the drugs used in status epilepticus? We go for diazepam or lorazepam. Then if this drug do not work after 10 minutes, then you go for phenytoin or phosphophenytoin. So in status epilepticus, what are the treatments that we are going to take the patient through in order to make the patient survive? We secure the airway first, then we give oxygen as a ventilation, then we put the patient in semi-prone position, then we give IV benzodiazepam. Then if that doesn't work, okay, we go for phosphophenytoin. If that still do not work, we go for phenobarbital or valproate acid. A good doctor should not stay on the bedside of a patient with status epilepticus for more than 20 minutes without arrangement of general anesthesia. It's very, very important because that is a critical condition. There are some drugs that are not good in female, but they are good in male. Like phenytoin, it might cause some side effect, ataxia, nystagmus, dysarthria. All epileptic drugs have its own side effect, but this phenytoin is very, very dangerous. It produces severe side effects. And carbamazepine also is not good in female. Then there are some drugs that are used in pregnancy, like phenobarbital and benzodiazepine. Thank you for this lecture. It is such an amazing opportunity meeting you back then in the physio round. We are coming head to head with more videos that will entertain and educate you all. Thank you.